And let's go. Hello, everyone. Good morning. I'm super excited for today's class, and now we're gonna be talking about another subject that is also extremely important for mainly for the sake of publication. This next class, you'll most likely not use it until the moment that you actually look to publish your own study. Because you see, when you're doing like an abstract, you mainly just need like the results and your the statistics, the descriptive well, the description of your data. However, for the sake of publication, there is another requirement which is the risk of bias. So what is the risk of bias? The risk of bias is basically you review the studies that you're going to include in your own meta-analysis or systematic review, and you see, all right, in my own review, I'm gonna criticize the studies that I utilized in my review, based on different factors that are to be analyzed in both in cohorts and in randomized control trials. So, as an example, this is one of the manuscripts that that we recently got published at the Journal of Neuro-Oncology, in which you can see that after all of the cool stuff like the data analysis, which we will review next week, I think, when we do a class on the risk. I'm sorry, on how to use Review Manager. There's also a paragraph on the risk of bias. So, as an example, the risk of bias is basically all right. We included, I don't know, 30 studies from which Oswald was pretty good, D'Amico was pretty good, and there are seven domains that we need to answer for in each of the studies. How was the risk of confounding, the risk of bias due to selection of participants, the risk of bias due to the classification of interventions, and the risk of bias due to missing data and all other stuff. So at the end, we're gonna have a really nice, um, like it's like a in Spanish we would call it a semáforo. It's like a driving lights, green
Oh,
light.
es como green light.
Yeah, but like how do you call them? Like I think we all know what I'm talking about, but I don't remember the specific name of it. But yeah, it's called a green light. That's it could be. Yeah, I believe you. I believe Ruben more than I believe.
Triage.
Okay, something like that. So at the end we're gonna have a really big like sheet saying what is the quality of each of our included studies. And also in the manuscript itself, you'll see that, oh, we reviewed 18 of our studies, from which we use these two tools. We use we're gonna be using two tools. The first one is the Robins. All right, the Robins is used specifically for cohort trials, while for randomized control trials, we'll be using the ROB2, all right? So the ROB2 is this another file that I just sent you guys, and the ROB2 is going to be used exclusively for randomized control trials, all right? So what we're gonna do right now is just basically do one of each. All right, we're gonna do one cohort and one ROB2, and so you basically guys just get a grip on how to do this risk of bias analysis. All right, but one really important thing is that while we're grading each of the studies, you basically have to have like an extra sheet. As an example, I usually have a sheet that's called concerns for risk of bias, in which what I do is basically each of the studies that I qualify like, oh, there's a concern of mine, you usually just like write it down. Because at the end of your risk of bias, you're gonna have um, all of your studies, and those that are classified as moderate or severe risk of bias, you have to like justify why did you select those. As an example, the primary analysis in these studies were relating to missing data, or they have loss of follow-up, or they didn't adjust for confounders. So those are like some of the main reasons why we would criticize some of the studies, all right? So let's begin, all right? Then we'll just grab any of the studies that we utilized, all right? We're gonna base papers. We're just gonna open this one. uh, let's do the ANASEF trial, all right? All right, so the ANASEF trial is a ran it's a clinical trial, all right? So for clinical trials, we're gonna be using the ROB2 tool, all right? So let's begin. You'll see that when you first open the file, it's gonna look like really, really nice. All right. So we're gonna click on ROB2 assessment form. All right. And it's gonna open up this document. All right. So there's like another, I think that's a really high quality um trial that I was analyzing recently. So I think I'm gonna use this one just because it's more standard. All right. So all right, let's begin. All right, so this is a randomized control trial evaluating the effect of something called a balloon-guided catheter, so which is basically, imagine when we're treating a stroke, sometimes we want to have like a catheter that opens up like a balloon, like just distal to the occlusion site, so we can better like manipulate the vessel that has been occluded. So this is a type of catheter that does something called a flow arrest, which is basically the same as a balloon guided catheter, right? So let's begin, right? So in this first study, we're just gonna classify it as an example. I always like to put the name and the year, so we're gonna put it as Dylan 2025, also Dylan 2025. All right. All right, so let's begin. All right, so the first step of this risk of bias assessment is just basically again we're gonna open it up and we're gonna go to the assessment form, and then we're gonna just open the document just to make sure that you guys can open it. So first we're gonna begin with the we have 5 domains in the ROB2, all right? And these 5 domains are basically, all right, number one, was the randomization process? How was the intervention classification? How did they manage missing data? How did they measure the outcomes? And how did they measure the results, right? So we're gonna begin with, was the allocation sequence random? All right. So basically, what they're asking over here is, hey, did the patients were allocated to both groups in a random way? As an example, if your study is just a clinical trial that was not randomized for patient selection, we're just gonna straight up put no, it was not. All right. However, in this study, we're gonna evaluate that. All right. It says here that okay. Here you go. Randomization. Participants were randomized. Excellent. Using a Pocock and Simon minimization method. All right, so in this case, it was randomized, all right? So this was a randomized control trial. There's some studies that are not randomized control trials, they're just open or non-blinded clinical trials. This one was blinded. Was the allocation sequence concealed until the participants were enrolled and assigned to the intervention? As an example, this means that if the patients were first um imagine that you get a patient and you put it into the randomization software, and it's like, oh, you got selected for the balloon guided catheter group, and then we tell the patient, hey, you're gonna be into the balloon guided catheter. Yeah. So which is not ideal. What we usually do is like either conceal the fact that they were randomized into a specific group, um, and like I think we never do that. We never do that. Like they are randomized and they're blinded, and then we just never tell them like what group they were randomized to, right? That is the ideal. They should not know when to what group they were randomized, right? So we're just gonna check it out. the patients were randomized. Let's just see if they actually told the patients if they were randomized, right? Um, they were blinded to allocation, right? So the participants did not know. So they were random and the patients never knew what group they were randomized, right? So it was randomized and it was concealed, all right? And the last one was, did the baseline differences between intervention groups suggest a problem in the randomization? All right. So can anyone tell me what is the objective of randomization? Yes, Ruben. A clinical trial can be non-randomized. As an example, you can be like, oh, we're gonna do a clinical trial in which all of the patients that came here between this month and this month were assigned into the intervention group, and afterwards they're just gonna be the control group. That's something that can happen. Um, actually, you can just like look for non-randomized clinical trial, and you'll see a lot of them. Like, basically, clinical trials are the best. Being randomized is the most effective way. However, you can also like non-randomize it. All right. So, can anyone tell me what is the purpose of randomization? Anyone? What is the purpose of randomization?
I think that the purpose is to ensure uh, that there's not a selection bias.
Okay, okay, that's good. Because after randomization, what should you have in terms of like the population characteristics?
We expect that it will be the same, the two.
Exactly, exactly. Very, very well, Andre. All right. So the purpose is that at the end of randomization, you should have two populations that are practically exactly the same. All right. Um, because that's something like that randomization does as an example. You'll see that if you have three groups, four groups, they usually tell you like, oh, they're like 3 years old, 6 years old, 5 years old, 6.5 years old, and then you should usually have like a p-value evaluating if there's significant differences between the groups, which the p-value can be analyzed either through an ANOVA, which is like one of the most common for numerical categories, all right? So if we go and evaluate the clinical trials that we just did, the purpose of randomization is get two populations that are almost similar. And check it out. They're like 76 years old, 74 years old, which is pretty similar. Almost half and half of sex divided populations, almost the same MRS, almost the same AFib population. So they're pretty much the same, all right? So that is the purpose of randomization, getting very similar characteristics, all right? Um, so can anyone tell me if we can do randomization in in cohort studies? Can we do randomization in cohort studies? No. However, we can do something to manage the selection bias, which is something really important that we just mentioned. But I'll tell you guys how to do that in a few seconds, all right? So the point is that we just identified that the populations are very similar. However, what is usually required is that after analyzing the study, the baseline characteristics, the study should tell you, oh, this study had we did an analysis, a test, a statistical test evaluating, oh, the difference between this study and this other study was analyzed with a p-value, and the p was equal to 0.9 as an example. So at the end, we evaluated the characteristics and we got this. So this study does not have that. And that is something significant. Like that's bad. What we usually should have is like, oh, we did a clinical trial, and then after doing the randomization, we're gonna test if there are like significant differences, right? So this is yeah, like this is not so good. Like you should have like a test after randomization eval. Let's see if the clinical trial from you see, look, in this study, we had the characteristics of the two arms, and you see that, oh, after dividing for sex, we have the p-value. After evaluating for age, we have the p-value. So this domain says, did the baseline characteristics suggest a problem with the randomization process, which basically means, did they do an analysis to evaluate for differences? So right now we're evaluating Dylan. So Dylan did not clearly state. So we can't say that, oh, there was no problem with randomization. Maybe yes, probably yes, but we're not like 100% like, oh, there was a big problem, but maybe there was an issue, all right? So afterwards, let's do a probably yes. So it is like a reason for concern, you know? So I'm just gonna put basically, if you have one sign of alert, we're gonna put some concerns. If you have two concerns, we're gonna put high, yes. And if you have no issues, we're gonna put low. All right. So we're gonna leave this one with some concerns. All right. All right. Sweet. If there's no other question, we're gonna continue to the next domain. All right. So the next domain. Were participants aware of the assigned intervention during the trial? All right, let's go check it out. What would be ideal is that after randomization, they never know what group they were assigned to, right? So it's like blinded also after the intervention, all right? So let's see. Um, all right. Okay. So okay. Okay, randomization. So we got all of the data. Uh, what I usually like to do is just look up for blind, all right? So let's just look up for the methods. Uh, okay. Okay, yeah, they were blinded. Okay. Both were blinded up to 90 days, which was the last moment of evaluation, all right? So they were blinded. Basically they were blinded throughout, so that's really good. So were the participants aware of their intervention? No. All right. So were the carers of people delivering the care aware of their participants? Because as an example, imagine that you're like a physician evaluating one of the patients that are like imagine that you underwent like a super experimental surgery that was like stem cells, that each of the procedure is like $1 billion. Like even if the person's like not in a good state, you're gonna be like, subconsciously, I know that you have like $1 billion inside of your body. So I'm gonna put like you're doing pretty well. Just because that's like a bias. It's like when you order a pizza, which is very expensive, you're gonna be like, man, this pizza is really good, even though it wasn't that good. Because you have like the bias before evaluating the pizza, even before you evaluated its flavor, you're like, oh, this was very expensive. I'm gonna say that it's better than it actually is. It's the same. So here we know that the treating physicians, all right, and the people evaluating the follow-up, the nurses were also blinded. So they were blinded, all right? So were the carers blinded? Yes, they were, all right? So so Oh, sorry. We should have put no because they were not aware, all right? Because they were blinded, all right? So if they weren't blinded, so if they were aware of the patient's classification, we would have to answer why. Like, were they the fact that they were not blinded? Do you think that influenced in some way? Um, Probably that would have been like a probably yes in those cases. Could that have affected the outcome? As an example, if if after imagine that the evaluators were not blinded, you know, but the patients after follow up they had to undergo a test in which they just I don't know answer an IQ test, which is super objective. And it doesn't matter if I know that you have $1 billion inside your body, your IQ test is not gonna be modified by my own bias, you know? So if if the way that you're being evaluated is super objective, even though I am not blinded, that shouldn't influence the outcome, you know? However, if me as the evaluator are like, oh, I'm evaluating your strength, that could be subject to bias. I hope that was clear, right? But it wasn't the case in this study, right? Was the appropriate analysis used to estimate of effect assignment to intervention? Yeah, you see that's like the same thing that we just evaluated. Like we don't know if the characteristics are like very different between the two studies. All right, so um uh oh sorry. Uh oh no, this is for mm, was the appropriate analysis used to estimate the effect of assignment to the intervention? That's like another relevant point to if the selection to intervention could have influenced the outcomes. So in this point, we're just gonna we're since in this study we're evaluating the use of catheters, and in this case, the catheters, like the evaluation is like pretty objective at the end. Like, oh, the modified ranking scale is the way that we're evaluating the patients. So, the modified ranking scale is real pretty objective. Like, if you're independent, you're like from a 0 to 2. If you're dead, you're a 6. If you're bedbound, you're like a 5. So it's like a very low risk that that the intervention group or the analysis could have influenced the outcomes. Um, However, in this case, it's like pretty much the same thing as the original question on, hey, was the allocation could have influenced the outcome? So in this point, since they don't have like a statistical analysis, we're not sure if it could have influenced the outcomes, all right? So we're not exactly sure if the assignment to each group could have influenced the effect, you know? So we're not sure. So we're gonna put like probably not, because it's like something pretty objective. But if they had like the statistical test, we would have just put like, oh, definitely not. But we're gonna just like put probably not. All right, let's see the. We're not sure of the criteria which the physician used to classify them. Oh, in this case, for this study, they just said that it was blinded and randomized based on. Uh, okay. Um, but it was based on baseline imaging and before treatment. So they did like have like a baseline before doing the randomization, right? So we're gonna put like probably not. Of the failure to analyze participants was an wait a second, what's going on? Okay, oh sorry, I like cut it. Uh, was there a potential for a substantial impact on the result on the failure to analyze the participants to the group which they were randomized? We're gonna put like probably not, because again, we are not sure if the fact that they were not analyzed to each of the groups, if that influenced the outcomes, you know? We're pretty sure it didn't, but we're just gonna have like some concerns, all right? Because again, if they had like analyzed, oh, after we randomized, they were perfectly similar. Oh, then in that case, that would put like, oh, was the inappropriate analysis used to estimate the effect of assignment? Yes, it was excellent. But no, we have some concerns, all right? Good. All right, then we'll continue. Missing data. Was the outcome for this data almost available for all patients randomized? So we're gonna check it out, all right? Most of the studies you should have in a map where we classify how was the selection done. As an example, after randomization, we have two groups, 66 and 65. So we'll see that there were no lost patients. Basically, we selected 100 and we analyzed 100. So that was excellent. So there was almost no loss of follow-up, all right? So was data available for nearly all participants that were randomized? All right, we're gonna check out the outcomes. And the outcomes, look, it was perfect. Like there was no loss of data. All right. So we're gonna put no. Oh, sorry. We're gonna put yes, it was available. And that's it. That's it. So low risk for concerns. All right. And we're gonna continue to the next one. That was it. You see, it's not that hard, all right? But you can see that it's pretty subjective. Like you have to pretty much like really analyze the study that you're classifying on the risk of bias, because you basically have to read it like really, really well, all right? Was the method okay? So now we're gonna talk about how they reported the outcomes. Was the method of measuring the outcomes inappropriate? Like imagining if you're evaluating postoperative pain, how would you evaluate postoperative pain? How do you think? How can you evaluate postoperative pain? Anyone? Questionnaire? Like from 0 to 10. How was your pain? Do you think so? Like something like that you're saying? Yeah, like that's like the most common way that pain is evaluated post-op. But Ruben, that is not the best way to evaluate pain, you know? Because that's pretty subjective. Like like my cousin, like uh, she has like a very low tolerance to pain. Like once I did like a very quick injection and like she was like, "Oh, that was the worst pain of my life." And it's like, I mean, it wasn't that bad. Like, one of the most objective ways to analyze pain, as an example, would be how much post-operative opioids do you need? Like, if you have two patients that one says, "Oh, I am in a 10 of pain," and you ask them, "Oh, yeah, that's like the same thing, Andre. Like from 0 to 10, how bad is your pain?" Like, so if you have a patient that's like, "Oh, I have a 10 in pain," and then you ask them, "Oh, do you want some morphine?" She's gonna be like, "Oh no, I'm good, don't worry." But then you have like another patient that's like writhing with pain. It's like a freaking she's like feeling horrible, but she says, "Oh, it's like a 5, doctor. Can I have some analgesics?" So in that case, it's like pretty objective, like, "Oh, hey, if all of my intervention group had no required opioids, but all of the patients that underwent this another surgery required a 3-day infusion of morphine for them to be able to like sustain their pain." Like, don't you think that's a little bit more objective, like having being able to measure like the milligrams? What do you guys think? Which is more objective? Like the exact dosage of opioid medications that they need post-op, or just like a questionnaire from 0 to 10? What do you think is better? What do you think is better? Exactly, Andre. Like having the ability to measure something more objective, yeah, like a dose is way better. However, it is more like rigorous, all right? Of course, how long do you take like it's way easier to just ask the patient, "Yo, how bad is your pain?" Oh, 10. All right. And that's it. Like it takes like 3 seconds. But like the opioids, you have to like actually do some data recording. So this is like if I saw a study that evaluated post-op pain that just evaluated a VAS, a visual analog scale, which is just like a 10 is like really bad and 0 is like really good. Um, so in that case, I would say that the measure of the method of measuring the outcome is bad, is not appropriate. However, in if they measure with opioid dosage, I would say that's pretty good, all right? So that was just an example in which we would scrutinize how an outcome is evaluated. So in this part, the way that they evaluated reperfusion is with something called a Tiki score, and the Tiki score is super objective. Like after imaging, you say like, oh, the vessel is wide open. Oh, that's a 3. The vessel is like 70% open. Oh, that's a tube C. Is like 50% open. Oh, it's like a 2B. All right. So that's pretty objective. So was the outcome inappropriate? No, it was pretty appropriate. All right. It's like a weird because they're asking like, oh, is it bad? No, it wasn't bad. So it was good. All right. So it's like a bit difficult to interpret, but yeah, this means there is no concern. All right. Could measurement of outcomes have differed between evaluate intervention groups? Like again, if we have like a visual analog scale, which is pretty subjective, um, and like imagine that that you have to answer a questionnaire that is done by the evaluator, all right? That could have differed because of the bias by the evaluators, all right? But this sticky doesn't matter who reads it. This is super objective, all right? So we're gonna put probably not. So there's probably like no difference between intervention groups, all right? Um, were the outcome assessors aware of the treatment? So there's another point like, oh, could the outcome have been influenced by different evaluations? So we just put no. And it's like, oh, but did they actually know that they were allocated to a specific intervention? So another point is like, oh, were the evaluators like blinded? It's like, oh, no, they were not aware. They were blinded, all right? And that's it, all right? So we're gonna put low risk of measuring outcome bias, all right? Okay. And at the end, we're gonna put domain number 5. Um, were the data that produced this result analysis in accordance to a pre-specified analysis plan that was finalized before unblinded, uh, available for analysis. So this basically means imagine that all of the data collection is blinded, and then just when we're finished and we're gonna start analyzing the data, we become unblinded. That is the best way to do it. So as an example, imagine that I'm like compiling the data for patients, and even though I'm like just like collecting data, I am not blinded. Like if a patient says that they're feeling kind of bad, and I read in their note, oh, they're feeling kind of bad. It's like, oh, but they did a $1 billion treatment. Maybe they're not that bad. I'm just gonna put not that bad in the spreadsheet for the analysis. All right. So here they say that they were blinded, um, that all of the analysis, all of the review were blinded up until the analysis. All right. That's what it says. I'm just gonna look up if there's like a specific phrasing. Okay, here you go. Statistical analysis. Um, mm, I'm just seeing, I'm just checking out if there's like something regarding blinding. But like they did follow up like a specific protocol. Um, okay, we're just gonna look up for blinding. Yeah, like what would be ideal is that they say like, oh, statistical analysis was also up until data collection was blinded, but it seems like all of the collection was done in a blinded fashion just before the analysis. We're not exactly sure, but we're gonna put like, was the data analyzed in accordance to a pre-specified plan? It was done by a plan, but we're not sure if it was blinded up until the data collection. But we're gonna put like probably yes. So if a numerical result is being analyzed, um, okay, look, this is really important to like be able to interpret. If the results are numerical, um, did multiple eligible outcomes, were multiple eligible outcome measurements available within a specific outcome domain? Imagine that we have like we evaluate for post-op pain. And as an example, we take a measurement morning, evening, and night. And it says in the method, oh, we only took the highest one. That would be subject to bias, because like I could have selected, oh, I'm gonna select the one that favors my data the most, all right? Um, However, if they're like, oh, we took an average of the opioid requirement, or we didn't, or we measured a single time at a specific time frame for all patients, that would be best, all right? So in this case, all of the evaluation were done at a single moment without any variation, which was at 90 days, all right? So we're gonna put multiple outcome domains. No, there were not multiple measurements. It was only one measurement, right? Um, could the results be have been selected due to multiple eligible analysis? Like imagine that I do 100 tests and I only report the good ones. Like that would not be good, all right? So in this case, they did report all of the outcomes. You see, everything is reported. Everything is reported. It's not like, oh, the tiki was good, and now I'm gonna hide all of the other data because it was pretty bad. All right. So that didn't happen. So multiple eligible analysis. We're gonna put no, probably not. And then, well, no, let's just put no because it was pretty good. So I'm gonna put low because they did follow a specific plan. Oh, and actually, if you just click each of the domains, if you have like any specific questions, the domains basically like describe like what are we looking for in each of the outcomes. So that's also like pretty useful, all right? Like, oh, changes to the plans were done. Like, oh, we were actually doing this, but at the end we couldn't get the data to work, so we did this another plan. But that didn't happen in this study. They followed a plan, all right? So anytime you have a question, you can just like click on the domains, right? So we're gonna go to the overall bias, and oh, can you guys hear me? There's like some instability. All good? Okay. So at the end, we can click algorithm result, and the algorithm says that we should put some concerns, all right? So in this case, that would be it for this ROB2 assessment, all right? So we're gonna click save. We're gonna click save. We're gonna close it. And look, like now it has the data, right? It has the data that we just selected, all right? So that's pretty good. That was really, really good. So now what we would do is go to this software, which is called the RobVis, all right? So the RobVis is basically just like a fancy website to make like really nice green light assessments. And basically we're just gonna like say like, oh, domain number one and number two was pretty good. And the last, oh, sorry, the first one and the, okay, here you go. Here's the ROB2 data set. So for this one, we would put, oh, there were like some concerns over here, some concerns over here, and then it was low for all the rest, and then it was like that. All right. And we only have one study as an example, all right? And the study was Dylan, 2025. All right. And we're just gonna save it, save this example. And then we're just gonna go to upload your data. We did our ROB2. Oh, traffic light. It's called a traffic light, guys. It's like too big, too difficult, too difficult. Sweet. Uh, okay. Oh, I think we should have like, oh, sorry. I clicked on another one. And now we're gonna generate the plot. And look, it's really beautiful. You see, and that was it. So for the manuscript, I would just like I can modify this thing, but like X studies were classified on ROB2 as some concerns due to um not evaluating the effects of randomization on population characteristics. And that's it. And then we continue all to the rest, all right? So, was there any question regarding the ROB2? So that's basically all we need to do, all right? Like just keep track on what you don't like about your studies. And that's it. All right. Any questions for the ROB2? Now we're gonna do a Robbins analysis, and that would be it for the risk bias, you know? It's like a little bit like tedious, but like once you do like your first one, it's way faster. All right. Any other questions? Was everything clear for this first part? All good? So, all good, all good. Okay, sweet. All right. Then let's finish the with Robbins analysis, right? So I always like to just like put like not saving it just so I can like continue using that forever. But all right. Now we're gonna go to Robbins, all right? So the Robbins is for cohorts, all right? Now, I'm just gonna tell you guys some analysis that we can do to improve the quality of our cohort study, right? So, uh, look, this is a study evaluating if patients that have glioblastoma, if they undergo more aggressive surgery, like taking out the extensity of the tumor and not leaving anything behind, if that results in better outcomes. Removing the entirety of a mass is called a gross total resection, all right? So uh, basically, if we evaluate uh, one second, one second, one second. One second, one second. Okay, so imagine that we're doing like just a whole in patients that are 95 plus, how good did they do? And we just do like, oh, out of the 95 year old, out of the 95-year-olds, like three did good and four did bad. And that's all I'm gonna report. Like if you just do like a straightforward analysis, that would usually be considered like a univariate analysis because you're just doing a fraction, you know? So you just do like, oh, 9 out of 10 did pretty good. However, there's something called a multivariate analysis. So multivariate analysis, what they do is like, oh, we're gonna adjust compared to like a reference group as an example. We're just gonna compare the 95-year-olds to the 66 and 65-year-olds, and we're gonna like take into consideration things along with the age. As an example, we're just gonna consider the effect of their gender, of their race, of their ethnicity, of the year of diagnosis, and we're gonna take a bunch of different characteristics that were relevant. Like, of course, tumor size was relevant, you know. So we're gonna do multivariate analysis, all right? So multivariate analysis in this case you just have to check out the methods. Like, if they report like, oh, we did a multivariate analysis, that's basically a pretty good way to control. Yeah, there you go. Like, they first reported just like, oh, this was better than that other one, you know? The hazard ratio was low, so patients that underwent surgery did better. However, once we did a multivariate analysis, the effect was still significant, you know? So initially it was like, oh, there was a big benefit. And after doing a multivariate analysis, it's like, oh, hey, after controlling for a bunch of other stuff, it was still super relevant, you know? Because sometimes, like, if I want to like correlate survival with smoking, you know, like, yeah, of course the people that smoke are gonna do worse, but like what happens if all of the smokers are like 90-year-olds and that's why they die sooner, you know, after diagnosis? Of course a 90-year-old is gonna live less than the average 40-year-old, you know. So multivariate analysis basically allow us to control for more variables in specifically the outcome reporting, all right? So was any question regarding multivariate analysis? If there's no other questions, I'll continue to the next study, which is for another measure of controlling for bias. Any other questions? Any other questions? All good? All right. So now we're gonna do another, I'm gonna show you guys another way to control for bias in cohort studies, which is called a match study, a propensity score match study. Does anyone know what a propensity score match study is? Do you guys know? Anyone? Anyone? Okay. Anyone? I'm just gonna get 3 seconds. Three, two, one. All right. Chicken chat. All right. No, no, no idea. It's okay. It's okay. Don't worry. But look, imagine that when we're doing a cohort study, there are tiers. All right. Like most of the cohort studies are like average, you know? But the more they control for bias, the better they are. If they report multivariate analysis, it's like, oh man, this study was so good. This study was so good. But if they do something called a propensity score match study, that is basically the best cohort study that you can do. You know, what they do is that imagine that you have two groups. One group with an intervention. This study was a study that I analyzed for a study for a meta-analysis that just got accepted at JNS, the Journal of Neurosurgery. And imagine that I'm studying a new therapy, a new surgery, which is called laser interstitial thermal therapy. So we're just doing a laser to treat epilepsy, all right? So we're just treating epilepsy with a laser, and then we have a group with that they just do like open surgery for epilepsy, all right? So imagine this. I have 185 patients that underwent a laser, and we have 400 open surgery patients that underwent open surgery. So what most studies do is like, oh, we're just gonna compare the the 200 laser patients with the 400 open surgery patients, and that's it. That's what's it's most common. But imagine that they're like, okay, if we have a laser patient that was African American, that was 30 years old, and that had epilepsy of the right side, we're just gonna compare that patient's outcome to an equivalent patient in the open surgery group that was also African American, 30 years old, and was a right-sided epilepsy. All right. So that's basically what we do with all the 185 patients. So we grab a patient with one set of characteristics in one group, and we compare that with an almost similar patient in the other group. What would happen? We're gonna get like 100 patients in one group and the same quantity of patients in the other group. But what will be the result of this? We will identify that at the beginning. Oh, yo, um, at the beginning we had like uh, one second. I'm just looking for a good example. Like, look, at the beginning, we had like, oh, one group had a 20 millimeter lesion size, and the other was like a 25 millimeter lesion size. Like, yo, this was like very different, like almost like a 25% higher size of lesion. So, of course, the outcomes could be influenced by this, you know? But after propensity score matching, you see that, oh, we lost 300 patients from the open surgery group. But at the end, look at the lesion sizes. They're practically the same, you know? So, so the point of matching is basically they also call it pseudo, like false randomization. So pseudo randomization is the same as matching. So at the end, the matching is the best thing that we can do in a cohort study to make the characteristics similar. All right. Any questions regarding matching? Any questions? What was I clear? So those are like the two most common ways that we can manage for bias in a cohort study. One is doing a matching, and the other one is doing a multivariate analysis. All right. But which one's the best? Matching and the multivariate are the best. All right. Any questions? All good? All right. Good. All right. Then we're gonna continue. Exactly, like it's not exactly randomization, but imagine that randomization allows us to have very similar characteristics of both groups. And matching also does this, you know? So like cohort matching is not the same as randomization, but leads you to the same result, which is having two populations with similar characteristics, all right? So it's not the same as randomization, but it results in the same, all right? So, all right, we're gonna do the this with this study that we just opened, the Joseph site, which is an excellent study, all right? So we're gonna call it Joseph site 2022. All right. So we're gonna begin. All right. Bias due to confounding. All right. So the confounding confounding basically means where the differences in group characteristics could have influenced the outcome. Like, yo, um, between your two epilepsy groups, could the lesion size have influenced the outcome? And if this study is not matched, if any study that you evaluate is not matched, you're gonna put yes, there is a potential for concern, you know? But in this case, and that's bad, that's why it's in red. But in this study, since it was in green, I mean, in this study, since it was matched, we're gonna put no. There is a very low risk for confounding, you know? All right. So if I were to put like that there was no matching in this study, I would have to answer question 1.2. All right. So let's just put as if I didn't put like there were like imagine if I just put like they are they have there's matching. I can skip this question and okay. If I put no, okay, okay. Okay, good. So if I put no, because there is matching, I can go to this one. All right. So did the authors use an appropriate method analysis that controlled for all confounding domains? So basically, like as an example, if they just matched for age, that would be a concern. So what did they match for? They matched for um oh, dude, they match for number of medications, seizure types, age, sex. They considered a lot of stuff for matching. So, dude, the matching was almost perfect. Did the authors use an appropriate analysis method? Yes, they did. It was super good. All right. Um, were confounding domains that were controlled for validly measured and reliably by the variables available in the study? Yes, because at the end they did an analysis evaluating for how were the differences. So this that was analyzed and it was excellent, all right? It was super, super good. All right, so we're gonna put no. Oh, sorry. Was it reliably analyzed? So yes, it was reliably analyzed, all right? Did the authors control for any post-intervention variables that could have been affected by the intervention? Uh, what is ideal is that like they don't control it, you know? Like if they imagine that they say like, oh, after the surgery, all the patients that died were not considered for analysis. Like, or like, oh, all the surgeries that went wrong, we're just gonna remove those from analysis. That would be pretty bad because they're hiding data. So we're just gonna put like no because they didn't remove any other patients. Like 185 were analyzed, and 185 were the ones that underwent like outcome reporting, you know? So that was pretty good. All right, next. Did the authors use an appropriate analysis method that adjusted for all important confounding domains and for time varying confounding? All right, so time varying confounding depends on like, yo, if one group was evaluated at 30 days and the other group was evaluated at 90 days, could that influence the outcomes? Yes, it could have. But in this group, they underwent something called the angle classification, which basically means like um that their seizure outcomes were evaluated at 1 year. So all of the seizure outcomes were evaluated at a similar time point. So in this case, we're gonna put no, there's probably like no risk of bias. Oh, sorry. Was the method appropriate? Yes, it was appropriate. Yeah, sorry. So we're gonna put yes, it was pretty good. And then were the confounding domains adjusted for, measured validly by variables available in the study? So was it measured validly? Like this, like something that we already answered. So we're gonna put yes. All right. So what was the risk of bias in this one? It was basically like low. It was really, really low. It was super good. It was super, super good. But as an example, if we have one no in this data set, like one red point, we would put like, oh, there are some concerns, all right? We're gonna put like, oh, there's a moderate risk of bias, all right? If we have one or two, we're gonna put moderate. If we have three or more, we're gonna put like serious risk, all right? Well, we're gonna put no. But if there was like no confounding, I mean, if there was like no matching and there were like a big concern for confounding, we would put like, oh, it is a risk and there is moderate. So basically, any study that does not have matching, we're gonna put like some concern in this part, all right? Or like a moderate. All right? All right, let's continue. Was the selection of participants in the study based on participant characteristics at the start of intervention? It's like what I just told you guys. Like, if they considered, like, oh, we're gonna evaluate the outcomes of surgery, but we're only gonna evaluate the surgeries that went well, all right? We're just gonna evaluate the surgeries where the patients didn't die. That would be pretty bad. Like, that's like hiding data again. So, what we want to do is like so it says what was the characteristics for inclusion in this study, like, oh, um okay, participants, inclusion criteria were children less than 18 years old with DRE who underwent one or the other. That's it. Like, it was pretty general. Like, they didn't like, oh, we're only gonna include patients that had like some concerning variable, you know? So this was pretty good. So we're gonna put like a low risk. Uh, okay, if no, go to 2.4. All right. So usually, like, as long as they did it like a good a like selection and like inclusion criteria, it's usually like pretty good. Most studies of on cohort studies are gonna be like pretty well define the criteria for inclusion and exclusion. If they don't define it, it's like a pretty bad study, all right? So let's continue. Do the start of follow-up and the start of intervention coincide for most patients? This almost doesn't apply for surgery. Like, all of the surgeries are like, oh, we're gonna evaluate it at 30 days, and that's it. Or like, oh, we're gonna evaluate post-op, and that's it. Like, imagine that I give you a medication, and for some patients I evaluate them like a 30 days, another day another group for like 60 days, and it like it's not equivalent, it's different. So in that case it would be a reason for concern, but in most surgical studies, since they all undergo evaluation at the same time, it's not that big of a deal. So in this study, all of the patients had their post-op outcomes immediately after surgery, and the surgery and the epilepsy outcomes at 1 year, you know? So this is gonna be our like a really low reason for concern. We're gonna put no. Oh, sorry. Uh, was the follow-up similar? Oh, so that's a yes. That's a yes. All right. Um, okay. And that's it. That's it. So there was a low risk of bias, all right? All right, so let's continue. Bias in classification. Were the intervention groups clearly defined? Of course, like there's like a very low risk cohort bias in surgery, because dude, it's like if we had two different surgeries, it's like pretty clear like what each group underwent, you know? But like imagine that you're doing a study on a medication and the dosing regimens are like very like uncertain. That would be pretty bad, you know? But in this case, there's like a really like the intervention groups in surgeries are usually very well defined, you know? Um, was the information used to define interventions recording at the start of the intervention? Like, oh, if they say like, oh, after surgery, we're gonna evaluate this, and this. So as long as before the surgery they know what they're looking for, this is like a pretty low risk of bias. All right. So we're gonna put like, yes, they did specifically state what they were looking for. And then could the intervention status have been affected by the known risk of outcome? Like imagine that a study reports the outcomes by, oh, then we divided the outcomes based on the patient that did well, the patient that did pretty bad, and like if we're stratifying the outcomes after the intervention, that's pretty suspicious, you know? It's like, oh, I finished a year of treatment, and then we're gonna divide the outcomes by the patients that I don't know, completely finished the study or like completely the medication treatment, and we're gonna exclude all of the rest. Like, hey, maybe the patients that didn't finish the medication regimen, maybe they did it because of a side effect or something that would be relevant for your study, you know? So could the intervention status have been affected? Like, oh, we're gonna include the intervention status uh but after knowing that they had bad outcomes. That would be pretty bad, you know? But in this case, for the surgeries, there's no risk of like modifying, you know? So we're just gonna put like, you know, there's a very low risk that you did pretty well. We're gonna jump to the next one, all right? Bias due to deviations from the intended interventions. So like, were there any deviations beyond what would be expected in usual practice? Again, this is surgery, so for how long do we have to like treat a patient before they stick to one group? It's just like, dude, after you did a surgery, you just stay in one group forever, basically, you know? So, probably not. Um, all right. So if your aim was to evaluate adherence, answer questions 3 to 6. All right. So, you know, again, for surgeries, it's way easier the risk of bias for cohorts because there's a very low risk that they're gonna be changing groups after the fact, you know? So we're just gonna put like a low risk of bias because we don't have to answer any of the other questions, you know? Um, and that's it. All right. Next one. Bias due to missing data. Were there any missing patients? Okay, there was a 4.8 missing on lesion size. All right. Oh, so here's the thing. If we have more than 95% of the patient data, this is good. Low risk of bias. All right. So if they have told me, yo, we lost 20% of the outcomes due to follow up, oh, that would be pretty bad. All right. But like in general, as long as they have 95% according to the Cochrane guidelines, if they have more than 95% of the initial data, that's pretty good enough. All right. So in this study, they just said 4.8. So were the outcome data analysis for almost all participants? Yes, it was available. Were the patients excluded? Let's see. Let's see. Like, look, the same number of matched patients were the ones that underwent analysis. Because sometimes they're gonna say like, oh, we lost 30 patients, and that would be pretty concerning, but they didn't, all right? So were they excluded? No. Um, were they excluded for any data sets? If we looked up missing and they were like, oh, we excluded patients if they didn't have their last known well outcome. That's why they were excluded, but it didn't happen here. Um, uh, and that's it. Low risk of bias, right? So this is like a really excellent study to evaluate like the risk of bias, just because there are very few patient follow-up losses. There are very few concerns of bias due to matching. This is pretty good. This is really, really good. Okay, bias in measurement of outcomes. Could the outcome measurement have been influenced by knowledge of the intervention received? Mm, what we're gonna look for is blinding, all right? There was no blinding. So there is a concern, all right? So it could have, probably yes, if in the study they say like, oh, there was blinding for the analysis um up until data collection, there was any sort of blinding, that would be a no in this domain. But there was some concern because there was no blinding, all right? So we're gonna put no. Probably yes, sorry. Were the outcome assessors aware of the intervention? Aware. There is no mention of this. There is no mention of this, all right? So they were probably aware of this, Probably yes. So were the methods of outcome assessment comparable amongst both groups? But even though there was a concern for the knowledge of, oh, these patients underwent a laser, they should do better, even though they are aware of that, due to the outcomes being very objective. Again, it's like if I evaluated a 0 to 10 scale of pain, and I knew what was your intervention, that could be subject to bias. But in my study, since it's very objective what I'm evaluating, seizure freedom, complications, in those cases, it's a very low risk of that knowledge influencing my outcomes. So, were the outcome assessments comparable for both groups? Yes, they were pretty similar, all right? Um, were they comparable? Were they the same? Were they evaluated both groups at the same times with the same scales? Yeah. Oh, sorry. I misread it. Sorry. Were they systematic errors in measurement? So probably not. I wouldn't say so. Probably not. All right. And at the end, what is the risk of bias? We have two yes. So we are gonna put moderate. All right. There is a moderate. But I know even though they weren't blinded, if this study had blinding, it would be perfect, but it doesn't have any sort of blinding, all right? So bias in selection of reported results is the reported estimate likely to be selected. So there is a low risk of being selected. Like, yo, if you're reporting that you had um like 20 complications and 54 complications, like is there like a big risk of you hiding complications? Like probably not. Like it's very hard to hide a complication. So I would put like probably not. uh okay, again, were multiple outcome measurements, and did they select only the outcomes that they wanted to report? Probably not. Probably not. Multiple analysis of the intervention outcome relationship? we're just gonna put like mm, they didn't do multiple analysis. They just did one. Like, oh, complications, dude. It's not gonna change the complications based on the group. Like, it's something very objective, you know. So again, if what they measure was like super objective and with a specific scale, with a specific time frame, it's usually gonna be a low risk of bias in this one. All right, probably not. Um, did they report like, oh, for the group of lasers, they reported all of these outcomes. And hey, how were your surgery outcomes? I'm not gonna tell you. They're secret. Oh, that would be pretty bad. But like they reported everything. So we're gonna put a no. So the risk of bias on the reporting on the hiding data was low. Was low. So the overall risk was uh it was pretty low. It was very, very low. All right. All right. But if they had more than one moderate, I would put like, yo, there is a concern for this. There is a moderate risk of concern, all right? But in this case, it was pretty safe. It was pretty safe, all right? Another thing is that if they had like a multivariate analysis, even though they didn't have a matching, the fact that they have like multivariate analysis, the multivariate basically completely negates the measurement of outcomes. A multivariate almost automatically makes it a low. All right. All right. And that would be it. That would be it. At the end, I would just in my manuscript be like, oh, um, my Robbins, I assessment had some concerns due to the bias of assessments due to non-blinding of evaluators. And that's it. That's it. All right. So the risk of bias is a little bit tedious. I hope that all the explanations were like clear. What I also really like to do is like anytime I have like a question, in this scales, there's like an explanation for each of the domains. Like if we go here to uh judgment tables, like, oh, what does confounding mean? Oh, confounding is like, oh, there was no matching, all right? Yo, what does missing data mean? Oh, like, oh, if they hit something, like basically everything I just said is in this table. So you can like read up on it. You can also like ask ChatGPT like, hey, I'm doing a Robin's eye. Um, this study doesn't tell me this fact. Do you think it has some concerns? And sometimes I have used ChatGPT to like help me analyze some study that I wasn't like completely sure of the phrasing of some outcome. But like that would be pretty much it. So, is there any other questions? Was everything clear? How are you guys feeling? Like, it is pretty tedious, but it's part of it. Like, you can't publish a meta-analysis or a review without having a Robbins analysis, all right? So, any other questions? Any other comments? How are you guys feeling? Was everything clear?
Yes, everything was clear.
Excellent, excellent, excellent. All right. Then
Thank
everyone,
you.
yeah, of course, there was a big pleasure. All right. I'm gonna thank you, Ruben. I'm gonna save this stop recording.